Good afternoon, everyone. Thank you for being at Community Chats. I'm Sandra Arevalo from Montefiore Nyack Hospital. I'm the Director of Community Health and Wellness. And today with us, we have Matthew Stryker. Thank you so much for being here from Amgen. Amgen actually works with patients with asthma, and they have this great program that helps people learn more about asthma and especially how to manage it. So that's what we're going to be talking about today. I know that a lot of us out there either have asthma, allergies, respiratory problems. So we're going to touch on all of that, but I'm not the expert. Matthew is. And Matt, tell us a little bit about Amgen and what your role is there.
Yeah, thank you so much, Sandra, for having me and welcome everyone. So my name's Matthew. So I work for Amgen. So Amgen's a biotechnology company based over on the West Coast, and they focus on multiple different therapeutic areas, one of them being respiratory and more specifically asthma. And my role with Amgen is over on the research and development side. And really one of my main objectives and purposes as far as my day-to-day is education, whether it's provider or in our case, patient education as well. So very excited to spend the next 45 minutes to an hour or so with all of you talking more about asthma. And like Sandra said, all the way from what is asthma to how is asthma managed. So I will.
So much. Go ahead, share your screen.
Perfect. Go ahead and do that. And
to our attendees, this is information that is good for the whole family. So if you would like to share this information, again, you can get to the recording and let people know about this. At least I'm gonna assure you that this is all science-based information and not a lot of the information that we see currently, like in social media or other websites that we don't necessarily need to trust that it's all scientifically based. So go ahead.
Thank you so much. And again, like Sandra had previously shared, want this to be interactive. So if you have questions throughout, if you would like me to review something again and or perhaps re-explain something or do a better job, just feel free to either come off mute and or drop your question in the chat or Q&A. And thank you, Sandra, too, for helping me survey those as well, just because of the functionality piece in terms of delivering and then monitoring as well. Perfect. But the program that we're speaking to today is LUMA. So Learn to Understand and Manage Severe Asthma. And while the theme is undoubtedly severe asthma, really a lot of what we're talking about today applies to both patients and or caretakers with the spectrum of asthma. So mild, moderate, and again, we'll focus on severe, but there's a lot of application to mild and moderate patients too. So just a quick housekeeping slide. So as Sandra previously shared, so I do work for Amgen, and this program is being presented on behalf of both Amgen and then our counterpart AstraZeneca. And we are sponsors of the program, but it is being presented in accordance with all the applicable rules, regulations, policies between the two companies, as well as the FDA. And then finally, this is an educational program, but please don't construe this as representation of any specific therapy being safe or effective for treating any particular disease. So educational only. So before we dive into the more formal part of the slide deck, just a couple of questions to start getting our minds in the asthma mindset, perhaps if we're transitioning from work to our lunch break today. But we'll think about these questions. There's 3 questions, and then we'll see the same 3 questions again at the end of the presentation where I'll share the answers. But we'll go through these 3 questions and then just think about these different questions as we navigate the slide deck in a little bit, because the answers will be peppered there. So I'll go over the answers at the end, but for right now, feel free to just either think about these different questions or drop what you think is the correct answer in the chat. So the first question is, how is asthma severity determined? A, by symptoms such as wheezing and shortness of breath. B, by the frequency of asthma attacks, C, by both the type and amount of medications needed to control asthma symptoms, or D, by the types of triggers that cause asthma symptoms. So I'll leave this up for a moment, but again, we're looking at how severity is determined. Okay, so next question. True or false? The immune system can be the underlying cause of a person's asthma. A, true, or B, false? All right. And then final question, recognizing the theme of this presentation is severe asthma. Patients with severe asthma are recommended to A, see an asthma specialist, B, work with a provider to create a written asthma action plan, C, track their asthma through an asthma journal, or D, all of the above. All right. So before we dive into really the core content from, what is asthma, to how is asthma managed, and speaking with Sandra, we're going to look at two sections to kick things off that are very relevant, perhaps to either yourself, a loved one with asthma, thinking about two different aspects. One, time of year in this specific scenario, peak week, and then also race/ethnicity as they relate to asthma as well. So first we'll kick it off with peak week, and really this is what we consider a perfect storm. And we'll talk about what peak week is actually in this slide. So peak week actually is right around the corner. So it's coming up in less than a week here. So it's the third week of September, which has been deemed asthma peak week. And this is really a call to action where anyone with asthma should be extra mindful during this month of September, and or if you have a loved one with asthma, just having an awareness and then keeping close connectivity to that individual as well. And what we see during peak week is that healthcare resource utilization, such as visits to the emergency department, these really pick up in September more so than other months. And we'll talk about the why on the next slide. And we also see increases in physician visits. So lots of statistics, and I'll just orient you to a couple of these on the bottom. For children specifically, what we see is that upwards of 25% of childhood asthma hospitalizations specifically occur in September. So representing a heavy weight of healthcare resource utilization in 1 month. Also, we could see missed school days, but keep in mind, peak week is not just applicable to children. It also applies and can be seen in older adults with asthma too. And what we could see is that almost a little over 14 million workdays are missed annually due to asthma. So peak week has a substantial burden on patients' quality of life, as well as other aspects such as work and school. So why do we consider peak week this quote unquote perfect storm? And really what we see is an appreciable increase in different triggers or the things that elicit or lead to that twitchiness of the airways and the symptoms that you may have previously experienced. And so why does this happen? Well, a couple reasons. First, we're starting to see cold and flu season begin, right? So we're at the infancy of cold and flu season, and just as a sidebar, as appropriate, perhaps, a discussion with your provider as far as vaccines go for flu vaccine. We also see an appreciable increase in ragweed pollen, and I can tell you, as a patient with allergies, not asthma, but allergies, this season for me has been especially bad because of all the ragweed, congestion, runny nose, etc. Additionally, mold spores become more abundant this time of year. And then finally, kids going back to school, more socialization, more interaction, which is fantastic, but also increased transfer of different bacteria and viruses because of that close proximity. So really, all of these together are kind of that perfect storm and result in that increased visit to the emergency room, perhaps, visits to healthcare providers for uncontrolled asthma. So importantly, what can you do to keep your asthma under control? So a couple different things to keep in mind. First is an awareness. So again, third week of September and even really leading up to that is when peak week can occur. So important to consider monitoring weather and pollen counts. And fortunately, a lot of different technologies, whether the internet, your smartphone, allow us the opportunity to track those more regularly. Having an awareness of your triggers and symptoms, and we'll talk about these in greater detail later on. Reviewing your asthma action plan, which is really kind of your playbook, if you will, as it relates to asthma. If you're into sports and can relate, or really, it's the foundation of care for how you can manage your asthma. And that's a discussion between yourself and your provider to create this asthma action plan. Additionally, and importantly, ensuring that your prescriptions are filled, not expired, you're taking them as prescribed, and then also just keeping your emergency contacts in the loop of communication as it relates to peak week. So before we talk about asthma disparities, any questions on peak week?
I don't see any questions.
Great, thank you for helping. So next, before again advancing into the core content, we'll talk briefly about asthma disparities among Americans. So in other words, like why perhaps are some individuals affected to a greater extent as it relates to asthma burden than others. So first, just some statistics on this slide as well as the next slide. So in this slide, we're focusing specifically on Black individuals and the fact that what's been observed based on the data is that Black individuals are more likely to experience worse asthma outcomes compared to white Americans. So left to right, this translates from the diagnosis up through the impact that asthma as a disease has on one's daily life. So we see increases in diagnosis in Black Americans compared to white Americans, more likely to be hospitalized 2 times in this case compared to white Americans, 5 times as likely to use the emergency department. And then finally, as it relates to mortality, there's a higher risk of mortality in Black Americans and specifically Black women with asthma. So now just pivoting a little bit and talking about Hispanic populations. We've talked about some of the statistics for Black individuals with asthma, but here looking at Hispanic populations and more so the inequalities that we know can contribute toward poor asthma outcomes. And these include education, access to healthcare, and then finally pollution. And left to right, what we can see is that compared to the white individual group, which is the blue figures here on the right-hand side of this teeter-totter, the teal or the green Hispanic represented group are reported as having less than high school education in about 1/3 of patients. No consistent source of healthcare, so 27% for Hispanic individuals, 17% of white. And then another major gap is that pollution piece, where that pollution burden is substantially higher in the majority of Hispanic individuals, 63% versus 17% less in white individuals. And, dialing down a little bit further, what we've observed is that Puerto Ricans actually have the highest rate of asthma compared to other racial or ethnic groups, in part because of some of this information we're presenting here. But just taking a step back and just considering disparities overall, what can really be contributing to this? And likely this is not comprehensive, but provides us a good snapshot of what are some factors really contributing to this disparities. And these can be bucketed into social disparities, such as economic stability, where poverty and employment can significantly contribute, structural disparities, so think access to healthcare, racism, as well as discrimination, behavioral, and this can actually tie back to medications or even just a treatment plan, such as trigger avoidance, and not being adherent with those recommendations, perhaps distrust in the healthcare system, environmental aspects that we had talked about, such as smoke and exposure to air pollutants. And then also, don't want to minimize it, but there is also a biological consideration where there's the genetic influence, or essentially kind of like a susceptibility, if you will, to, in this case, asthma. But we've talked a lot about the why in terms of the disparities, but importantly, how do we address the disparities? So we don't want to just identify the problem, but what is really being done to help address these asthma disparities? And again, not comprehensive, but a good framework for what's being done to really bridge the gap to ensure that all patients with asthma have appropriate access to healthcare, and hopefully better outcomes across the board. And we can think about these in 4 different groupings. So policies, research, education and communication, and partnerships. And as it relates to policies, this is going to be improved healthcare insurance coverage, working to bridge some of the structural gaps that we had talked about, such as improving wage and also reducing racial wage gap, and perhaps not shown on here, but the differences in wage gap between males and females, ensuring that there's access to affordable housing and quality housing by extension, and minimizing exposure to any known triggers. Research, really important to ensure that the appropriate patient populations are represented in the clinical research. So we had talked about, for example, Puerto Ricans being disproportionately or more heavily affected by asthma. Well, we want to make sure that when the clinical trials are done, that group is represented because they're most likely to have asthma. And importantly, too, not only the patients within the trial, but also the researchers themselves to help garner trust and as well as enrollment and better understand the impact that certain therapies may have on asthma-related outcomes. Education, communication. So that's what we're doing here today, which is fantastic, but don't stop here. Continue to have a growth mindset, improve your understanding of asthma. And then also this ties to providers as well. So patient and provider education. And then finally, partnerships. So recognizing that no one organization, no one group is going to be able to help close the gap on the disparities. And really it is a multi-stakeholder partnership with the patient at the center to improve these outcomes. So we'll move on to the next section, which now is kind of more the core content for our presentation. But I don't see any questions in the chat or Q&A, but anybody have any questions or things that they want to discuss as it relates to disparities?
Matt, do we know why people from Puerto Rico have a higher incidence of asthma?
Yeah, great question. So I think a lot of research continues to be explored. And just jumping back a few slides here, I think in part, and again, this isn't capturing everything, but some of these different tiles here, I think kind of capture the why behind the disparities that we are seeing, the education piece, access to healthcare. And I mean, this is a pretty substantial gap here too, as far as exposure to potential triggers. But again, more to be unpacked as far as the why between Puerto Ricans specifically having the highest burden for asthma. And perhaps it also relates to genetic susceptibility. Now, that last part I'm not 100% on, but there could be an increased risk.
I don't know if there is any research that talks about where Puerto Ricans actually live, like if the rates of asthma are higher for those people living, you know, in the mainland as opposed to the island, for example, where the air is less polluted, maybe, I don't know.
Yeah,
Or
no,
something like that.
very great thought, right? So if we think about perhaps like, you know, Puerto Ricans that live in New York City and perhaps the Bronx, like the burden there of asthma, perhaps I would anticipate be much higher than the island of Puerto Rico. But yeah, very, very thoughtful. And I would anticipate there'd be research, but yeah, I'll have to do some digging to see if I come across anything. Appreciate that. All right. So next we're going to talk about asthma as a chronic disease of airway inflammation. And just to unpack this a little bit, when we say chronic disease, we're thinking about long-term disease. So disease that would be with us for typically our lifetime, but importantly, in recognizing that this disease can often be controlled. So when we say chronic, think of other diseases like high blood pressure, diabetes. Those are other examples of chronic disease. And then lastly, airway inflammation, probably not something that we're always thinking about, but if you've ever stubbed your toe or had a cut and seen how red it can get around the affected area, that represents inflammation. So somewhat similar, we see inflammation within the airway. And again, asthma is a disease of the airway, as we all recognize. So we'll look at first some statistics around just how common asthma is, and then talk more about presentation, diagnosis, and a few other elements. So asthma is a very common disease. And as you can see here, across the US, about 25 million individuals are affected with asthma. And of these individuals, upwards of 10% can have severe asthma. So about 2.5 million individuals. And we'll talk about how severe asthma is actually defined on the next slide. And then if we take those 2.5 million individuals with severe asthma, upwards of 50% or over 1 million individuals are actually having severe uncontrolled asthma, which again, we'll talk more about. But bottom line here is that asthma is very common. And while patients with severe asthma don't represent the majority, fortunately, it is uncontrolled disease is common in patients with severe asthma. So what is severe asthma? And we talked about this a little bit toward the beginning of the presentation, but the bottom line here before kind of getting into the nitty-gritty of the definition is that severe asthma is defined by the medications a patient is on. So if you have severe asthma, perhaps you're currently taking a high-dose inhaled corticosteroid, which is one medication used to treat asthma or class of medications, as well as another class called a long-acting beta agonist, or sometimes we say LABA for short. So if you're on both of these medications, you'd be considered having severe asthma. Now you can be controlled on these, or if you have severe asthma, you can be potentially uncontrolled despite treatment with these medications as well. And again, we'll define uncontrolled in the next slide. Lots of different options for the management of severe asthma. I won't spend time on this slide talking about these different options because we'll actually circle back to these, but just a snapshot of the different options out there. And recognizing that despite using these higher doses of medication, following the treatment plan, important to recognize that patients with severe asthma may not have their asthma under control and may experience asthma attacks or exacerbations. So important to A, have awareness of severe asthma, and then B, continue that conversation with your provider. So we've defined severe asthma, again, ultimately defined by the medications that a patient's on, but how do we define uncontrolled asthma? Well, first, uncontrolled asthma happens when your symptoms really are still there despite following your asthma action plan, or again, kind of your blueprint or your strategy for how to manage your asthma. and the symptoms are still there despite reducing your exposure to triggers. But how do we define this? So we've talked about kind of the what, but how do we define this? Well, a quick and easy way to define uncontrolled asthma is based on the rules of twos. So some of the indicators of severe uncontrolled asthma are highlighted on this slide. And I will call out, if you answer yes to one or more of these questions, this may suggest that your asthma is not controlled. It really is a call to action to schedule a visit with your healthcare provider and discuss these results. So first in the top two, these relate to one class of medications, SABA, or short-acting beta agonist reliever. So if you use your SABA more than 2 times per week to relieve your symptoms, that might be an indicator of uncontrolled asthma. Similarly, if you refill that SABA medication more than 2 times per year, that can be another indicator. As it relates to symptoms, if you awake at night with asthma symptoms more than 2 times per month, that can suggest uncontrolled asthma. And then finally, another class of medications, if you use oral corticosteroids like prednisone more than 2 times per year, that would be another indicator. So again, just to reinforce, if you answered yes to any of these, this might be a call this is a call to action really to connect with your healthcare provider and just talk about your asthma control and the symptoms you're experiencing. So now we're going to focus on the core content for this section, which is that asthma is a chronic disease of airway inflammation. And what's building out right now are essentially different airways. So left to right, left represents a patient without asthma, and then the right two represent a patient with asthma. So what you can see here is that on the left, there is no inflammation or constriction. And how do I know that? Well, if you look at the light blue color here, it's a large opportunity for air to flow in and out of the lungs. And really, you could think of this almost like an expressway, right? So the cars representing air, and in this otherwise healthy patient without asthma, this is going to represent non-rush hour time. So maybe like 6 a.m. or 2:30 p.m. Now I recognize maybe it's a bit tone deaf being around New York City to say that because it's always busy, but you get the idea. Now in the central visual here, this is a patient with asthma, and after being exposed to different triggers, perhaps like a virus or ragweed, the body is going to react to that and overly react to that. And what it does is it leads to that inflammation that can make it harder to breathe and some of the symptoms you may experience. So you can see here that compared to the left, this airway has tightened up a bit. And back to that traffic example, we're not quite peak rush hour yet. It might be 7:30 a.m. So we're getting there, but the cars, or in this case, the air, is still able to flow pretty freely. And then finally, on the right, this visual represents, again, another patient with asthma, but this individual is experiencing an asthma attack, or also an exacerbation is another term you might hear. And in response to those triggers, you see more inflammation, more airway tightening, mucus production, and an even smaller airway because, again, the body's responding to those different triggers. And this is like peak rush hour. So the air is still going to move, the traffic is still going to move, but it's a little bit more challenging just because of the inflammation and constriction that we're seeing here. So we've kind of talked about the visual of what's occurring in the lungs, but what does it look like? And perhaps you've experienced some of these symptoms as well. So what we're looking at are some hallmarks of airway inflammation and narrowing. And what I do want to call out is that your symptoms are unique in that what you may be experiencing for asthma symptoms as it relates to maybe when you were initially diagnosed or when you have an exacerbation or asthma-related event, yours are unique and may be different than perhaps a family member who has asthma, a friend, etc. So do want to call that out. And these symptoms can include elements such as coughing, chest tightness, shortness of breath, or even wheezing. So often non-specific, and we have some other different tests we can do to help hone in on asthma, but be mindful that these are some of the hallmark symptoms of asthma.
Matthew, are there any differences between the symptoms from adults to children?
That's a good question. So oftentimes, going back here, children, I think, would often present with wheezing, and it can make diagnosing asthma a little bit challenging. And what you might see is that a diagnosis of asthma may often be delayed in children just because challenges with the diagnosing and some other testing elements to land on a definitive diagnosis. But wheezing tends to be a dominant symptom in children among the other examples highlighted here.
And another question is how come that sometimes children grow out of asthma and some others don't?
Yeah, great question. And this is a little bit controversial. And, if you ask perhaps another clinician or provider, you might get a somewhat different answer. So like the growing out piece is sometimes where people get hung up. So what might happen is you earn or you get diagnosed with that initial diagnosis of asthma as a child, right? And then from there, sometimes people are regarded as growing out of their asthma, and that could relate perhaps to changes in hormones as one goes through puberty and such. The controversy is such that, like, do you truly grow out of your asthma, or is it still there in the background and perhaps your triggers have been substantially reduced, or did you definitively grow out of it? So I'm kind of skirting around your question just because there's not a great answer, but some patients with less severe disease as children grow out of it, if you will, and become much more controlled, if not go back to baseline, like almost pre-asthma. But some individuals, especially children with more severe disease, tend to advance on and carry on the asthma component into adulthood. And I will call out too, like patients can not have asthma as a child or adolescent and then be diagnosed later on in life with asthma. So bottom line here is just acknowledging, and a lot of research is being done here, that there are many types or flavors of asthma. I'm an ice cream guy, so I liken this to, multiple different flavors of ice cream. We know that asthma can be classified as allergic or non-allergic, but suffice it to say that there are many different ways to classify asthma. Asthma onset in childhood versus older adults, different ways based on your labs. So yeah, sorry, I digressed a little bit from the question there, but it made me think of that other piece of it too.
Yeah, and coughing and wheezing and chest tightness, that can also happen when you have an allergic reaction, right? So how do you differentiate like an anaphylactic shock, which is part of that allergic reaction, from an asthma attack, or is that the same?
Yeah, great question. So two different things, right? So an anaphylactic attack would be the body's hyper-responsiveness to a given allergen that the body's overreacting to. There might be respiratory symptoms there in terms of shortness of breath, but the visuals highlighted here, we're trying to reflect symptoms of asthma, but it can be challenging. And I didn't call it out, but I appreciate the acknowledgement. The symptoms that patients can present with, and perhaps you presented with, can often be non-specific. So coughing, could be because of asthma, could be because just somebody without asthma has some type of infection going on, and coughing is just the body's way of trying to clear that infection. Chest tightness could be a heart attack taking place, so further workups required. Shortness of breath, maybe heart failure. So just trying to reinforce that the symptoms here are non-specific, And that's actually a great segue into this slide here, where a provider can take what you share with them and then really work to hone in on the diagnosis of asthma based on the assessment of symptoms, your medical history, as well as the physical exam. And so just briefly, medical history, I mean, we often think about sharing our different diseases perhaps that we've been diagnosed with, but importantly, medical history is importantly going to include occupational history. So what do you do for a living? And perhaps that relates to some of the symptoms you're experiencing based on what you're exposed to. Social history, so are you a smoker? Maybe that serves as a trigger. And also family history, which may indicate increased risk for certain types of asthma as well. Physical exam, whether the provider's going to listen to your lungs, look at you. Importantly, and this is kind of where we can really hone in, lung function testing provides a great objective way to assess how well the lungs are performing. And this can provide and help guide us toward a diagnosis of asthma or another respiratory condition, perhaps that may look like asthma in terms of symptoms, but the lung function testing suggests something else. And I will call out lung function testing in your doctor's office might be what is called spirometry, where you have a champion that's really encouraging you during different lung function measurements to perform your best, just so we can get adequate measurements to help guide that diagnosis potentially. But at home too, patients can do what is called peak flow monitoring to assess their lung function day to day. And this is not as rigorous, and essentially it's a tube you can blow into to capture personal best and change from baseline. But there's different flavors, again, back to that theme of lung function testing. We had talked about symptoms, blood tests. So again, back again to that theme and flavor of different asthma elements. Blood testing can help identify perhaps what type of asthma you have. Do you have allergic asthma? Do you have another type of asthma that's diagnosable via blood testing? And that can also inform potential treatment decisions too. And then finally, we have exhaled nitric oxide, essentially a non-invasive way to measure inflammation within the lungs. All right. So next we'll move on and just recognize the role that the immune system can play as it relates to asthma. So before jumping into this, a few different pieces to just align on here. We recognize and appreciate that the immune system is involved in really is kind of our line of defense against different invaders like bacteria, viruses, etc. And what we see is that in patients without asthma, they'll have a typical response, if you will, to these different invaders. The immune system will increase in response to a given invader, and then it'll go back to baseline. What happens in patients with asthma, you might see an exaggerated response to something that should not be responded to, or perhaps have an unusual response leading to those symptoms. And now I pulled through this word triggers, but you might hear irritants as well. And these are the things that will interact with the airway, ultimately leading to the immune system's involvement, and then after that, the symptoms perhaps that you may have experienced. Some of these triggers may be obvious, and they could be allergens like cat dander, dog dander, ragweed. Some may be less obvious, such as emotions, and even weather or climate. So thinking back to last year with all the wildfires from Canada, that could easily serve as a trigger for some patients who are more susceptible. But we'll talk about the importance of knowing your triggers and perhaps how to track your triggers in a little bit, because they can change, which makes life more challenging, right? So just a visualization here as far as how these irritants lead to that immune response and symptoms. So we have that airway on the left, right? So back to that traffic analogy, This is pre-rush hour, the air is flowing, but then we get exposed to those different triggers, right? So the pollen, the ragweed, those come in and interact with our airways. Then from there, that's going to turn on certain immune cells that become activated. So our soldiers become active. And then we get that inflammation, that constriction. Now we're starting to go from pre-rush hour to rush hour with the airflow. And then ultimately, the symptoms that you may experience, all the way from coughing, chest tightness, to the more severe forms of asthma where patients might have full-blown asthma attack leading to hospitalization, ER visit, etc. And then if you're more of a text learner, this information on this slide is essentially what we talked about on the last slide, just in that triggers like the pollen and the ragweed turn on certain immune cells leading to specific responses, and different immune cells lead to different immune responses specifically. And this, again, might inform different treatment options. And then again, pulling through the blood testing that we talked about, this could be used to assess both the type and the level of immune response. But your doctor will review your results with you, and this again will likely help inform potential treatments for you. And then finally, we'll talk about the role that you can play as one with asthma or as a caretaker for one with asthma. But before wrapping up with this last section here, just want to pause to see if there are any questions that anybody may have or anything I can clarify.
No further questions.
Thank you. So we've talked about different ways to approach asthma, and a very common way is the asthma action plan. And this is, again, kind of the blueprint or the strategy document, if you will, that's going to outline ways to reduce and treat your exacerbations, manage your symptoms, and again, get back to control of your asthma. So this is made up of 3 different parts that we'll touch on: lifestyle modifications, the asthma journal, and then finally medications. And really, the development of this plan is a dialogue or a discussion between your healthcare provider and yourself about what to do if things are going well, when your asthma is getting worse, and when you're experiencing an exacerbation, which is truly a call to action to seek care during an asthma attack. And important to recognize that this should be referred to regularly, the asthma action plan. Bring it to your medical appointments with your providers because it can change, especially based on triggers, different treatment options coming out that may be more appropriate for you, changes in background medication. So be sure you have a copy of this with you. So the first part of the asthma action plan is the asthma journal. And really, this can be a written journal, an electronic journal, whatever works for you in terms of tracking. But this really kind of collects a lot of different information to help guide that discussion with your provider, whether it's your daily peak flows, which again is that home lung function monitoring. If you've had an asthma exacerbation, working to track your different exposure to irritants and triggers. So, if you document perhaps that you were exposed during a walk to ragweed, see how your symptoms look over the next couple of hours, over the days, to see if maybe that's an identifiable trigger. Medication use, like your rescue inhaler, the SABA that we had talked about, oral steroids, and any changes to your daily life, such as work or school or sleeping, that impact your quality of life or your ability to do your day-to-day routine. So the second part after the asthma journal are lifestyle changes. So some of these are more specific to asthma on the left, and some are just more general and applicable for overall health and wellness. But important to always follow the recommendations that your doctor provides. But just walking through these as it relates to asthma around your home, some of these you may be able to do, some of them you may not be able to do, depending on your living situation, house versus apartment, condo, etc. But around your home, vacuuming your carpets, which can really be a reservoir for different triggers. So ensuring you're vacuuming on a regular basis. As it relates to the bedroom, washing your sheets and blankets, considering allergy covers, limiting pets in the bedroom, especially if that's a known trigger, reducing humidity to around 50%, because again, that can serve as a potential trigger for some individuals. Sealing doors and windows to limit outside exposure of triggers like ragweed and pollen. And then, if applicable, working to eliminate any pests such as insects and rodents. And then in general, again, more heart healthy and overall healthy too. Healthy weight, eating a well-rounded diet, ensuring regular exercise as tolerated, breathing exercises to manage stress, which we know is a trigger for asthma, avoiding smoke, which will go a long way, not just for asthma, but many respiratory diseases and beyond. And then healthy sleep habits too. So limiting, exposure to your tablet or your phone before bed, TV time, etc. And then finally, rounding out the asthma action plan. So again, this has included the asthma journal, lifestyle modifications, and then finally, the treatment plan. So before going through this briefly, similar to the symptoms aspect, all treatment plans are unique, and what's represented here may not be included in your specific treatment plan. So just want to acknowledge that. But going counterclockwise here, some of the different medications you may see, and some we've actually talked about, are short-acting or rescue medications for as-needed use for asthma exacerbations. So that might be like, albuterol is a common one that's used that you may have heard about. We have our long-acting controllers, and unlike the short-acting ones, which are as-needed use, our long-acting ones are for daily use, for daily asthma control. Most commonly, these come in the form of an inhaler, but some are tablets. You might see for either asthma exacerbations or in severe cases for long-term use, oral steroid use for when asthma control is needed. So this would be like prednisone, for example. Allergy medicines. So if you have that certain flavor of asthma, allergic asthma, allergy medications may be prescribed to help you manage any known triggers that are allergens contributing to your asthma. And then finally, biologic medications, and these tend to be reserved for patients with severe asthma, and these are very targeted therapies that work to address specific drivers and immune parts that are contributing to your asthma. So to round out the asthma action plan, again, journal, lifestyle changes, and medicines. So bringing it all together now, we've talked about a lot of different elements from peak week, which is right around the corner, third week of September, asthma disparities, and then at its core, the power that you have over your asthma. So we've talked about how common asthma is. Again, 25 million here within the US, over 1 million patients with severe uncontrolled asthma. We've recognized the role that the immune system plays, leading to the symptoms that you may have experienced previously. And then finally, how you can manage your asthma or support a loved one with asthma as it relates to lifestyle modifications, and importantly, that asthma action plan and that discussion you have with your provider to be an active participant in care. So I would be remiss if, in my formal life as a teacher, if I didn't share some additional resources with you. So LUMA on the right-hand side is the program that we just focused on, but some other great resources and sites to check out. The American Lung Association has some great asthma-specific resources, as well as many other respiratory resources. Allergy and Asthma Network as well is another very bountiful website to check out for educational tools and resources to support your journey. And then finally, just to wrap up the questions, first question again, how is asthma severity determined? A, by symptom severity, such as wheezing and shortness of breath. B, by the frequency of asthma attacks. C, by the type and amount of medicines needed to control asthma symptoms. Or D, by the types of triggers that cause the asthma symptoms. So what do we think? How is asthma severity determined?
And we invite our participants. You can write the answer in the chat box.
All right, maybe some people are finishing lunch right now before going back to work, or have something else going on, but asthma severity is guided by, or is determined, I should say, by the type and amount of medicines needed to control asthma symptoms. So think that high dose inhaled corticosteroid and LABA that we had talked about, so that determines if you have severe asthma. Next question, true or false, the immune system can be the underlying cause of a person's asthma? A, true, or B, false?
I'll say
right.
A, true.
True, exactly. So, depending on the different triggers that are coming in and interacting with our airway, different types of immune cells can be activated, but bottom line is that the immune system can be an underlying cause of a person's asthma. And then finally, for the questions that we covered previously, patients with severe asthma are recommended to A, see an asthma specialist, like a allergist or pulmonologist. B, work with the provider to create that written asthma action plan. C, track their asthma through an asthma journal. Or D, all the above.
I'll say B, all of the above.
Yeah, exactly. So again, we're talking about here patients with severe asthma. These can be applied to patients with mild, moderate in terms of different elements here, but patients with severe asthma are recommended to see that specialist, work on the asthma action plan, journal via the asthma journal, so all of the above. And then finally, in terms of the program today, just welcome your thoughts here. How would you rate this program? A, which would be 4, which is great, all the way down to D, 1, which is poor.
I will say A, but I might be biased.
Appreciate that. Thank you.
And
while everybody's,
go ahead.
I was just gonna say, while everybody's digesting and that last question, this is the last slide, but I do see that question came through. And thank you for that question. How can doctors hone in on what is causing asthmatic issues after blood, scratch tests, under the skin testing? Yeah, so great question. So I will acknowledge this can be challenging. The blood testing can provide a more guided understanding of what's causing it. So we talked about allergens, and allergens is a very broad term, but either via blood test or what are called skin prick tests, where your doctor will actually inject teeny tiny doses on your skin of what may actually a bunch of different allergens, see how your body reacts. It's very localized, it's just in the skin. That can help providers understand what your specific triggers are. So again, blood or skin prick tests to inform the different allergens. Additionally, there's different types of blood testing that can be done to see other immune drivers. Probably one of the most common ones would be eosinophils. So it's a mouthful, but eosinophils essentially it's another immune cell that can be a major contributor toward one's asthma. But bottom line is the blood testing, and then also things like the skin prick testing can help hone in. but the journal that we had talked about from your perspective as a patient or caretaker, that can kind of complement that to really dive into what is driving the asthma and the symptoms that somebody's experiencing.
And I think that's the importance of the asthma journal as well, because it helps us to realize, what's really going on. It's hard for the doctor sometimes, just through the story and being that they are with us for like 15 minutes in a visit, to identify those triggers. We can do a much better job when we keep that asthma journal.
Absolutely, absolutely. Great. Well, I want to be sensitive to everybody's time. I know it's the middle of the workday for many of you, so I'll hang around, but I don't see any more questions in the chat, but appreciate everybody's attendance. Sandra, thank you again for the collaboration here over the past 2 presentations, and thank you all for attending as well.
And we look forward to having you back, Matthew. So please
Thank you. I appreciate that.
Keep in touch.
Absolutely.
And thank you to all
so
of our attendees for attending today and for your questions. Thank you so much. See you next week. Bye-bye.
Bye-bye.